All right, so we are going to start our review about diuretics and electrolytes. So thank you for all the attendees that are actually on time today. So let's start with our review about diuretics and electrolytes. So please, if there is some question, just raise your hand, or you can ask me directly. Okay, so let's start. So this review, we are going to just focus on the areas that are going to be needed in order to have the concepts of the diuretics, right? So let's start. So we have diuretic drugs that accelerate the rate of urine formation, right? So diuresis is make you void in more constant and more volume, right? So diuresis, what is doing diuresis at the end? Is blocking the sodium reabsorption. Okay, so blocking the sodium reabsorption, they are going to decrease the volume because the water is going to follow the sodium. So we already know that. So let's talk directly about pharmacology, and the first thing that we need to talk is about the loop diuretics. Okay, so what is doing the loop diuretics? First of all, are going to act at the level of the loop of Henle. And what is doing is inhibit the absorption of sodium. So the prototype of medication is the furosemide. Then we have the potassium-sparing diuretic, and this potassium-sparing diuretic is going to spare potassium. In the previous one, when we are talking about the loop diuretics, they are going to excrete sodium and excrete potassium. And meantime, the potassium sparing is going to secrete or excrete sodium and is going to spare or keep the potassium. So that is going to have a lot of nursing considerations that we are going to talk in a few. Then we have the thiazides. Thiazides let's put it this way, are the small gans of all the diuretics. So are less stronger than the loop diuretics and the potassium-sparing diuretics. Loops and potassium-sparing are the big guns, so those are the big weapons for diuresis. Meantime, thiazides are going to be the small gun. So please pay attention on this. Thiazides is going to be used for initial treatment for hypertension. Okay, used for initial treatment for hypertension. You know that you have the pre-hypertension, hypertension 1, hypertension 2, hypertension 3. So depends how is the blood pressure increase with the time. The first line of treatment for hypertension is going to be the thiazides. And just remember, it's very simple. All the names are going to end in thiazide. The carbonic anhydrase inhibitor are going to mostly work at the level of the proximal convolute tubule. And again, as all the rest of the diuretics are going to decrease the reabsorption of sodium. We have the acetosolamide and the metasolamide, mide. So those are the suffix for this medication. Osmotic. So osmotic diuretics are going to be mannitol. This is a very important medication. The mannitol is going to be used for a few things. Number one, decrease intracranial hypertension. It's osmotic because mannitol is being made by a carbohydrate, it's a polysaccharide that cannot be absorbed. So that is going to, they are going to pull water, and that is going to increase the diuresis in the patient. One of the things that we need to remark here, that mannitol is administered by IV infusion through a filter. Look at this filter, because of possible crystallization. And here I show you a picture. We have the syringe with a needle, and this device they put it in between, that are going to be a filter that is going to stop the crystals that are going to go through the IV. So mannitol is giving an IV infusion through a filter because of possible crystallization. Another thing that we need to remember is that osmotic, the mannitol is being used for decrease the intracranial hypertension. Intracranial hypertension. As you can see, and we can repeat this many times, is that the diuretics are going to produce hyperglycemia, Who are the ones who produce hyperglycemia? So please remember, don't forget that, hyperglycemia produce mostly all the diuretics, but not the potassium-sparing diuretic. So loop diuretics, loops are going to produce hyperglycemia. Thiazides produce hyperglycemia, and osmotic diuretics, like in this case, can produce hyperglycemia. So you can tell this in patients, for example, who are diabetic patients. So it's very important to remember that. All right, so here we have the loop diuretics. That is the most effective. That is one of the big guns that we was talking about. And the commercial name is going to be Lasix. That is one of the most common, frequently prescribed when you have hypertensive crisis. Hypertensive crisis is when you have your blood pressure more than 180, systolic blood pressure increase. That is when you are going to use the loop diuretics. All right, so let's start talking about the loop diuretic. That is the first diuretic we will talk about. Is that the adverse effects are dehydration because they are going to make you lose water, and electrolyte imbalance. So loop diuretics, what they are going to do is to get rid of the sodium, and they are going to get rid of the potassium too. So what does it mean? That you can lead into hyponatremia and hypokalemia. Hyponatremia and hypokalemia. So any electrolyte imbalance, as we mentioned before, are going to have muscle weakness, anorexia, lethargy, and dysrhythmias. So why? Because potassium mostly is going to have as late side effects the cardiac arrhythmias. Okay, in general, all the electrolytes are going to have muscle weakness, nauseous and vomiting. That's why I put it here as anorexia, because you don't want to eat when you have nauseous and vomiting. And lethargy. Lethargy is actually already a second level of weakness, muscle weakness, so you become slow. All right, so potassium supplements may be needed. So you can tell here that loop diuretics lose sodium and potassium. We want to lose the sodium because that is going to make lose water, but the potassium is actually depleted. In this case, we need to have supplements of potassium. The supplements of potassium could be, for example, a simple banana. It could be orange juice too. They have potassium. One of the always you need to pay attention in this medication is the digoxin or lanoxin. Digoxin is going to be used for arrhythmias. Digoxin is an antiarrhythmic, and is going to be used for increase or improve the contractility of the heart when you have a heart failure. So it's very common to use the digoxin and lanoxin. The problem is that this digoxin, what is going to do is synergism with hypokalemia. And hypokalemia, they are going to have synergism with the digoxin, making the digoxin reach toxic levels very fast. What is the consequence about that? Is that they enter into bradycardia and cardiac arrest. So you need to be very careful when any of the diuretics who are going to make lose potassium. Well, another diuretic that make lose potassium is going to be the thiazides and the osmotic. So all the diuretics can lose potassium minus, but not the sparing potassium. Okay, so digoxin is a huge high yield for NCLEX. All right, so we already know, and you must, please, open eyes, open ears here, you must be familiar with the names of the diuretics. As I mentioned before, these names are so common that in NCLEX they mostly ask you to be more than familiar with these names. We have furosemide, etacrinic acid, torsemide, and bumetanide. So for this, you remember we was talking about some mnemonic, and because this is a recording, I need to do it. They're going to make it here. Just a moment. All right, so the mnemonic is going to be phytobum, phytobum. F means furosemide. ET means etacrinic acid. TO means torsemide. And BUM means bumetanide. Okay, so you can see here that the mnemonic is going to be very simple to remember. Very simple to remember. We have furosemide of F, ET is etacrinic acid, torsemide, and bumetanide. All right, so let's start talking about the loop diuretics. Okay, so here we have that, as you can tell, we are going to repeat many times, who produce hyperglycemia, loop diuretics, thiazides, and osmotic diuretics, okay? So that is one of the things. So because the loop diuretics are going to make lose potassium in huge amounts, you're going to have very careful this interaction between the digoxin and the loop diuretics. They can produce hypokalemia, and they can lead into digital toxicity. Now, some considerations about general about diuretics is, first of all, you need to, in DS and diet, they're going to have, for example, in this case, you're going to have decrease the potassium in the case of potassium-sparing diuretic. Potassium-sparing diuretic. Potassium-sparing diuretic. So that is needed when you have potassium-sparing diuretic, you have too much potassium. So you need to be careful with the levels of potassium. But when you are taking thiazides, loops, or osmotic, you need to have some supplements of potassium. Okay? Always watch for the digoxin. We have iron fluids. So daily weight, you need to check how the medication, you need to assess how is the efficacy of the medication. So you need to look for the all what is the input and the output of fluids. Fluid restriction, because you want to get rid of water, daily weight. We have here unbalanced fluid and electrolytes, hyperkalemia if renal disease. So something that is very important to remember that especially potassium-sparing diuretic are going to spare potassium, right? And you never going to use when you have renal disease or kidney failure. Why? Because the kidney is not working and cannot get rid of the excess of potassium. So that is going to lead into hyperkalemia. We need to be careful with effect of diuretics, especially with elderly patients. Elderly patients are very easy to get dehydrated. So you need to keep the lab test and daily weight measurements in this patient. The heart rate, we are going to see if you're losing water, you're losing volume in the blood. So what happened? You are going to decrease your cardiac output. If you remember, the blood pressure is equal the cardiac output multiplied by the peripheral resistance, and the cardiac output is equal volume multiplied by the heart rate. If your volume is going down, actually in order to keep the same cardiac output, your heart rate need to go up. So that's why you're going to have this increase of heart rate. But at the same time, that compensation have a limit. So this cardiac output, when they go down, they are going to have low blood pressure. And that's what we call the orthostatic hypotension. The orthostatic hypotension. Another nursing consideration is to give the medication during the morning, no at night, because they are going to have diuresis during the night. Increased risk for hypotension. So now let's see one example. If you have some patient who having taking diuretics and they having nauseous and vomiting, and severe nausea and vomiting, you need to refer to the doctor. So why? Because nausea and vomiting are going to make you lose electrolytes. And the diuretics are going to be related to the loss of balance of electrolytes. So that means that you're losing, mostly in the cases, losing sodium and potassium. Let's talk about thiazides. Thiazides is the primary use of treatment for mild to moderate hypertension. So the first line of treatment is the thiazides. Thiazides, we have chlorothiazide, thiazide. So mostly all the medications are going to end in that. So what they are going to do is to block the reabsorption of sodium as the rest of the diuretics. So this is very important for NCLEX. So please just remember we have that the thiazides can produce hyperglycemia. Who produce hyperglycemia? Loops diuretics, thiazides, and osmotic diuretics. So mostly all diuretics can lead into hyperglycemia. The explanation we can do another time, but just remember hyperglycemia. They are going to lead into hyperuricemia because the excretion of uric acid, especially in the thiazides, are in the loops diuretics and thiazides are going to decrease the excretion of uric acid. That is going to lead into gout. So bouts of gout. Again, we are going to be very careful with the toxicity of digoxin because of the hypokalemia. So everything or anything that can lead into hypokalemia can lead into toxic levels of digoxin. All right, so let's talk about potassium-sparing diuretic, and you already know the mnemonic for potassium-sparing is TAS. TAS is the triamtiren. We have the milorite, and we have the spironolactone. So those three are going to be potassium-sparing. Okay, so let's keep going with this. What is the main side effect of the potassium-sparing? Is the hyperkalemia. So what we are going to be careful here is these people or these patients are going to use potassium-sparing diuretics in order to decrease the blood pressure, right? And one of the nursing considerations is these patients do not receive, decrease the levels of salt in the diet. So they are going to have some replacement. So we have some salt replacement that is based on potassium. Carbonic anhydrase inhibitor, the acetozolamide, is one of the weakest diuretics, and we are going to use this for glaucoma, carbonic anhydrase inhibitor. So please, we have another that is the osmotic diuretics, right? The mannitol that we was talking about at the beginning, they can be used for glaucoma too. But the mannitol is used to decrease the intracranial pressure. Meantime, the carbonic anhydrase inhibitor is going to be used for glaucoma. They can be used for high altitude sickness too, but especially glaucoma. All right, so side effects of the carbonic anhydrase inhibitor are going to, again, hypokalemia. The hypokalemia is going to be in relation with the toxicity levels of digoxin. Again, Diuretics that produce hyperglycemia, can increase their glycemia, are going to be loop diuretics, thiazides, and osmotic diuretics. So we are talking about the carbonic anhydrase can lead to into hyperglycemia. Okay, so here we have the carbonic anhydrase inhibitor, and please, I want you to write down this. We have two situations that probably you see we was skipping for a moment, is about the metabolic acidosis, metabolic acidosis, and who produce metabolic acidosis. Metabolic acidosis are going to be done by the osmotic diuretics, so that is the carbonic anhydrase inhibitor, that is the metabolic acidosis. Meantime, the metabolic alkalosis is being seen in the use of loop diuretics and thiazides. So we have metabolic acidosis is the carbonic anhydrase inhibitor. One of the names is the acetosolamide. You are familiar with that. Acetosolamide, metabolic acetosolamide. So you can remember that metabolic acidosis can be seen in when we are using acetosolamide. The rest can be seen metabolic alkalosis. All right, so the combination of diuretics are going to be the triamterene, amiloride, spironolactone, plus one thiazide. Thiazide here, thiazide here. So the combination of diuretics, that is hypertension stage 2, because stage 1 we have one medication, stage 2 hypertension we use two medications, and that are going to be a combination of the potassium-sparing diuretics plus one of the thiazides. So this is thiazide, spare potassium. All right, so we need to remember that the nursing considerations is going to be very important to always think about the I&O control and the daily weight. If the patient is going to gain weight in 2 days more than 2 pounds, you need to report. If the patient is gaining weight more than 5 pounds in a week, you need to report that immediately. All right, so let's talk about our electrolytes. Talking about electrolytes, you need to know the values of the sodium and potassium, as we show here. And we are going to see some nursing considerations about this. And what I want just to go is in here. So we have hypernatremia and hyponatremia, hyperkalemia and hypokalemia. So hypernatremia, the main cause of hypernatremia is diaphoresis or excessive sweating. That is when you are, for example, losing a lot or you're sweating because of overheat. They are going to be, if you taste your sweating, it's going to be salty, correct? But you're losing water too. So hypernatremia means that you have high concentration of sodium in blood. How come is you are losing sodium? It's because you are losing more water than sodium. You're losing more water than sodium. So sodium are going to be concentrated in blood, okay? In the hyponatremia, very simple. We was talking about the diuretics. What is doing a diuretic is to inhibit the absorption or reabsorption of sodium. So you have at the end less sodium in the blood. That is going to lead into hyponatremia. So hypernatremia, excessive sweating. You're losing more water than sodium. So sodium is concentrated. Hyponatremia, you're going to use, for example, diuretics. Diuretics are going to make lose a lot of sodium. We have hyperkalemia and we have hypokalemia. Hyperkalemia, number one thing that you need to remember of is that you cannot, is going to happen hyperkalemia when you have acute renal failure. So renal diseases or kidney diseases. So you need to be careful. So if you're going to give, for example, potassium-sparing diuretic, the kidney cannot get rid of that potassium. So you're going to start getting high levels of potassium. That is going to lead into arrhythmias. So that is the hyperkalemia. In hypokalemia, again, diuretics is going to come here. So, for example, the loop diuretics and the thiazides are going to lose sodium and potassium. And that is going to be the most common cause of hypokalemia, diuretics, okay? So we have hyponatremia and hypokalemia. Hypo, one of the most common is the use of diuretics. And hypernatremia is excessive sweating, and hyperkalemia is going to happen when you have kidney failure. Okay, so talking about the signs and symptoms of these four at the same time, what they have in common, if you see in the chart, they are going to be producing weakness, muscle weakness. So that is what we just need to remember. What is going to be another signs and symptoms that we are going to see in the next slides. All right, so potassium. Please open eyes, open ears about potassium. Potassium is, you know, the levels of potassium. When you are going to administer potassium, this potassium always need to be diluted in about 20 cc of water and a slow infusion. Otherwise, the potassium in high levels can produce arrhythmias and cardiac arrest. So always potassium need to be diluted. Second is, in some cases we need potassium supplements in the case of loop diuretics and thiazides. So those are the most common to use, so you need to supplement of potassium. So if we talk about hyperkalemia, the hyperkalemia is the high levels of potassium in blood, okay? And what is hyperkalemia? What is the most common cause of hyperkalemia? It's going to be renal diseases, right? Renal diseases. So renal diseases means that the kidney cannot remove the excess of potassium from the blood, and that can lead into hyperkalemia. Signs and symptoms of hyperkalemia: muscle weakness. You are going to have hyperkalemia. If you see potassium, they have, the K have like two legs, right? Mostly they produce cramps on the legs. These arrhythmias could be arrhythmias. Mostly potassium imbalance can lead into cardiac problems. Meantime, the sodium are going to, first of all, lead into nervous system. Sodium, nervous system, nervous system, and hyperkalemia, you have the legs here, just to remember, are going to be it's going to be the cardiac problems. Hypokalemia. Causes of hypokalemia, you can tell that are going to be diuretics. Another thing that you need to pay attention is the laxative. Laxative is, when you're constipated, they're using laxative, and they increase the amount and number of the BMs, of bowel movements, and that is going to be a way to lose potassium. That can lead into hypokalemia. Vomiting, diuretics, right? All right, so here we have in acidosis, metabolic acidosis, and metabolic alkalosis. In metabolic acidosis, you can see hyperkalemia, and metabolic alkalosis, you can see hypokalemia. What happened here is that this is the cell here, and this, when you have high levels of hydrogens in the extracellular space. This is the extracellular, and this is the intracellular. Okay, so what happens when you have too much acid, so you have acidity here, what happens, they are going to make the potassium, the hydrogens get into the cell and the potassium coming out. So especially in the red blood cells, the red blood cells are going to exchange. When you have too much acid in the blood, the hydrogens are going to come in exchange to potassium. So what happens? You are going to have hyperkalemia. The opposite, when you have the cell here, this is the cell, and you have low hydrogens, okay? So what happens is the hydrogens are going to come out to increase the hydrogens, but they are going to come in potassium. So in that case, that is going to be hypokalemia. And I make a summary here. When you see alkalosis, mostly can be, you can see hypokalemia. When you see metabolic acidosis, you can see hyperkalemia. So potassium, heart, right? So, but in common between any alteration of sodium, any alteration of potassium are going to be muscle weakness. And hypokalemia, just remember we have the muscle weakness, anorexia, nausea, vomiting, lethargy, and cardiac dysrhythmias. So those are relevant for the NCLEX. So please. All right. So hypokalemia, when you're going to give potassium to the patient, never going to give it undiluted. So always they need to dilute the potassium. Otherwise can lead into cardiac arrest. All right, so sodium. Sodium, we are going to see that when you have mild hyponatremia, you can give increased salt in the food, so PO. When it's moderate to severe hyponatremia, you need to treat it by IV. All right, so hypernatremia, we already talked. What is the most common cause of hypernatremia? Is going to be dehydration, right? You're under the sun, too hot, you start to sweat a lot, you lose a lot of water, and you lose some sodium, but you lose more water than sodium, so the sodium will be concentrated in the blood, okay? All right, so that is hypernatremia. We are going to keep going here. So signs of hyponatremia. So please open eyes, open ears here. We have lethargy, hypotension, stomach cramps, nausea, vomiting, diarrhea, and seizures. So just remember sodium, Na, nervous system. They can lead into the orientation. They can go into seizures, and they can go into coma. At the beginning, these patients are going to be very irritable, so very active. Then they're going to depress the nervous system, going into LOC, alterations of level of consciousness. Start with lethargy, then they start to have seizures, and they can end into coma. Okay, so here we are going to talk about solutions, especially about colloids. Colloids, what are colloids? So that is IV solutions. We have, first of all, the crystalloids. The crystalloids are the normal safe solution, dextrose and water, and the lactate ringer. They are going to use for fluid resuscitation. We talk about that in class. One thing I want to talk about this is that when you are going to give, in addition, blood components in transfusions, for example, you're never going to use dextrose, okay? You're always going to use normal saline solution. Why you don't use dextrose? Because the red blood cells in contact with the concentration of 5% dextrose produce hemolysis. So everything you're going to add with blood, they need to be done with normal saline solution. Colloid. Colloids are large particles in solution. For example, we have albumin. Albumin and dextran head starch, but mostly we use albumin. What is doing albumin? Albumin is going to retain water. You know, it's a protein that retains water. So you need to be careful with the development of fluid volume overload, especially in those patients who already we don't want to have overload volume in the circulatory system like heart failure. All right, so here, as we mentioned here, blood products should be given only with normal saline solution, 0.9%, because dextro 5% in water can cause actually hemolysis with any blood product. So you already know that we use only normal saline solution. We have the cryo precipitate plasma proteins that mostly is going to be used for acute hemorrhage for more than 50%. But there is another consideration here. When you are doing any transfusion or any component of blood, you need to look always for reactions in the patient. So any reaction like headaches, like lightheadedness, like some itchiness or some redness, any part of the body, they are going to tell you that probably the patient is having some transfusional reaction. So what you need to do is to discontinue the infusion right away. We have products, some other blood products, like for example, fresh frozen plasma. Fresh frozen plasma. Review what we have in plasma. In plasma, we are going to have mostly proteins. Okay, proteins, hormones, etc. But plasma is given to patients who has some problems from coagulation process. So that is going to provide proteins, and the proteins are included the clotting factors. Clotting factors are proteins. So that's why in cases of problems with coagulation, we are going to give fresh frozen plasma that increase those factors. We have the PRBCs that is for acute hemorrhage, and that is when the indication is to increase the amount of red blood cells. So when you have hemoglobin lower, when you have hemoglobin very low, mostly what is desirable is to use the packet red blood cells. And when the hemorrhage is less than 25%, okay? The whole blood is going to be given when we have acute hemorrhage from more than 25% of the of loss of volume. Okay, so talking about fluid concentrations, we have the hypotonic is what we call is going to increase the volume of the cell because water is coming into the cell, and that is, for example, the normal saline solution. Normal saline solution is the only solution that can be administered with blood components. So remember that. Okay, hypertonic. Hypertonic is going to make shrink the hypertonic solution that you're giving into the blood are going to make take water from the cells out into the circulatory system. That is going to be used for ascites and severe hyponatremia. Okay, so let's keep going here, and I think that is about, let me go over a little bit more review here. All right, so we already talked about we was talking about the carbonic anhydrase inhibitor, right? So these guys, what they are doing is the acetosolamide, right? Acetosolamide, what kind of metabolic acidosis or metabolic alkalosis? Remember, we have the carbonic anhydrase inhibitor. The most common is the acetosolamide. Acetosolamide produces acidosis, okay? Acidosis, with metabolic acidosis, not metabolic alkalosis. Plus, they are going to, all diuretics mostly are going to elevate the glycemia, so the levels of glucose in blood. We have, for example, the spironolactone. What of the main side effects are going to be what? The hyperkalemia. We have the mannitol or we have osmotic diuretic that one is being used for what? For cranial hypertension, intracranial hypertension, and they are going to be used with a filter in order to because they can be crystallized very easy, and you don't want crystals getting into your bloodstream. You need to know already about the orthostatic hypotension. So mostly all diuretics are going to lead into orthostatic hypotension. Orthostatic hypotension. So you need to keep in mind your nursing considerations. Another thing is the effect of the how soon can be an IV furosemide make effect. How soon is going to make effect the potassium-sparing diuretic. That is going to start making diuresis in the patient in about 5 minutes. About 5 minutes. About 5 minutes. You already know, in addition, we're talking about the digoxin. Digoxin is going to produce a bradycardia. It's actually used as antiarrhythmic. So if you are going to decrease even more the potassium can produce toxic levels of what? Of digoxin. And that can lead into cardiac arrest. So the question is, who produce hypokalemia, right? So all the diuretics except the sparing potassium diuretic. Okay, you know already what are your nursing considerations for diuretics, and you need to be very careful in the intake, output, and daily weight. Okay, so with that, I guess we cover many of the topics. Please, if you review the video, probably you're going to have just review 1 or 2 times. Mostly is high yield all the topics that are important for these topics. So if any questions, please just let me know. Hello?
Oh.
Okay, Alicia?
Yes.
Okay, so thank you for attending. Any question?
No, I don't think so. I think I wrote everything down.
Okay, Joanne?
No, nothing. Thank
No,
you.
nothing. Okay. All right, so thank you, everybody. I will see you next time, and we'll see you tomorrow. Gracias.
Thank you.
Thank you.